Welcome, everyone. Thank you for joining us for the showcase series by the Johns Hopkins University Office of Government, Community, and Economic Partnership. This series highlights different Johns Hopkins programs with a strong relationship with the state of Maryland. My name is Will Smith. I'm a state senator from Montgomery County. I'm also chairman of the Judicial Proceedings Committee. I'm also an alum of Johns Hopkins University. Today, I'm very excited to be a part of a discussion about the innovative program pioneered at Johns Hopkins Hospital on reducing gun violence. As I'm sure everyone is aware, gun violence is a growing public health crisis, and we need to use every tool in the toolbox to address it. Joining me today is Dr. Nathan Irvin. He's an assistant professor in the Department of Emergency Medicine at Johns Hopkins Hospital, and he's currently engaged in this work and is going to talk to us today about the Break the Cycle program, which is a hospital-based violence intervention program with the primary goal of preventing recurrent injuries and supporting health and growth. Dr. Irvin has been with Johns Hopkins Medicine for 13 years. He earned his medical degree at Harvard University and completed his residency in emergency medicine at Alameda County Medical Center's Highland Hospital in Oakland, California, where he was chief resident. Dr. Irvin is the assistant dean for medical student DEI and holds interest in social emergency medicine and addressing many of the health and behavioral problems that affect people living in urban communities. Two such threats are HIV/AIDS and violence. He's currently the clinical director of the Johns Hopkins Bayview Medical Center Emergency Department HIV/HCV screening program, working to identify and to get people with these diagnoses of HIV linked into care. Additionally, he is engaged in work related to youth violence prevention and endeavors to help trauma-informed hospital-based violence intervention programs. That is a mouthful, so we're certainly joined by a well-credentialed individual. Doctor, welcome. Before we get into the discussion, I do want to go over a couple logistics for those tuning in. This is a webinar and it will be recorded and it will be posted to the Hopkins at Home website with captions included. Additionally, the questions and answers function has been enabled during this webinar. So please feel free to type the questions in there. We'll do our best to respond to as many questions as we can in the time that we have. And with that said, Dr. Irvin, it is over to you. Welcome. It's good to be here with you.
Oh, thank you for having me, Senator Smith. It's truly an honor to be able to speak with you all today to really, I think, share a labor of love, not only I work on, but many other colleagues and partners that are part of the Break the Cycle violence intervention team. And so I'm excited to talk to you about something that is really one of the missions behind why I'm in an emergency position. And I think it's a critical issue we have to address as a society forward. So the goals of this talk are just threefold. I'm going to give you an overview of some firearm injury, both nationally and locally, and highlight some of the challenges of survivors of violence that we see in the hospital, and then ultimately provide an overview of the work that's being done at the Johns Hopkins Hospital as part of the Break the Cycle violence intervention program. So if you look at the U.S., nationally, about 45,000 individuals will be killed by a firearm each year. There's about 60% of which will be suicide. The other sort of 40% or so will be attributed to homicides, with a small fraction being attributed to unintentional injuries or legal interventions. But by and large, the majority of firearm injuries are going to be suicides or homicides. And fortunately, firearm injury has become the leading cause of all youth between the ages of 1 and 19. And so this is, I think, an unceremonious reality in the United States. It's something we really have to figure out how to get ahead of, because children shouldn't be losing their lives before they have an opportunity to live. If you look at the individuals most impacted by violence, it's going to be younger folks. And so this is a graph that highlights the reality that individuals between the ages of 15 and 35 will, by and large, the overwhelming majority of individuals will die by firearm injury. And once you get past that sort of age group, people will start to die from normal kind of causes of death, things like cancer or chronic illness, other kind of things. And so it's a high risk window. If we can get people through that window, then we can sort of put them on a better sort of trajectory towards positive health. And if you look at the populations most affected by violence, you're going to see that as Black males. The homicide rate of Black males is about 20 times that of their sort of white counterparts. And if you look at our female residents, Black females will also have higher rates of violent injuries than their non-Black counterparts. And so it is truly an epidemic that's driven primarily in the backs of Black males. And so what does this look like here in Maryland? I showed you in that previous graph that nationally, about 60% of the deaths are actually attributed to suicide. But in Maryland, it's the opposite. About 65% of our firearm injury deaths are attributed to homicides in Maryland, and about 35% of which are suicides. And that accounts for about 800 people that are Marylanders being killed each year. About 66% of which will die at the result of homicide. And as is the case in the national situation in Maryland, the leading cause of death for youth is going to be firearm injury as well. Pulling down to Baltimore specifically, it's a challenge that we've faced for many, many years here in the city of Baltimore. On average, between 300 and 350 individuals were killed in the city of Baltimore. Up until last year, we had close to about 262 individuals who lost their lives. And so we had a 22% reduction in firearm injury deaths throughout that year. And the overall majority of homicides that occur in Baltimore are attributed to shootings that you can see with these bright red bars. And where do these shootings occur? Well, they occur in essentially a butterfly pattern around the city of Baltimore that's focused on the west side of Baltimore, where shock trauma is the main kind of hospital center there. And then on the east side of Baltimore, where Johns Hopkins is related. So we oftentimes will take care of a lot of the patients on the east side of the city, and shock trauma will oftentimes see a lot of individuals from the west side. And this is a slide I think really highlights the reality that not only is violence prevalent in that same sort of butterfly distribution, a lot of other kind of comorbid social challenges that individuals will face. And it's important to recognize this because when you're thinking about how to support individuals who are going to be coming in with violent injuries, you have to think about all the other cognitive etiologies to their risk to being a victim of violence. And so things like historical redlining, things like unemployment rates of HIV and Hep C, rates of like home lending, a lot of those things are going to be occur in the same sort of pattern that we're going to see when you think about where the violence occurred. And so not only do we have to attend to the violence itself, we have to think about those upstream factors that are particularly driving violence. And violence is not a one-time thing. The reality is that violence is a recurrent process. And so if you take 100 individuals who are shot and stabbed, there have been studies that have shown that upwards of 45% of those individuals will be re-injured within 5 years, 20% of which will be fatal. There's been some data actually done at our Johns Hopkins Hospital looking at recidivism. We found that our recidivism rate is closer to about 16%, and that the risk of mortality double for each recurrent injury that these individuals sustain. And so this is a high stakes game. And we know that these individuals are high risk of dying if we don't do something to intervene in their lives. It's also very costly. There's estimated up to $229 billion that are spent on individuals related to violent injuries. And that's related to healthcare, related costs, lost income, employer-related costs, legal costs, individuals having to be part of the carceral system. All those things generate tremendous costs to us as a society. And the average inpatient cost for an individual that comes in and has to be admitted for their injuries is about $35,000. And so it's not an insignificant cost when you think about the healthcare costs that people are acquiring. I think more importantly, there's tremendous human costs. These are young individuals who are brothers and fathers and uncles and individuals who are going to be pillars of our community if given the opportunity to really kind of live out the lives that they truly envision for themselves. And these individuals are being stripped from us, and those bullets keep on traveling. It's not just the individual that dies from a gunshot wound that's impacted. It's their neighbors, their siblings, their children. Those individuals who have to continue to live their life with continual trauma, continual kind of exposure to this needless violence. And so these costs are uncalculable. And I think it's important for us to recognize that we got to do something to sort of make this right, to make this better for individuals. And so when I'm thinking about our individuals that come to our hospitals and they are victims of violence, they survive their violent injury, I think there's a lot of factors that are kind of coming together and triangulating together. One, they're high risk, high mortality, high rates of recurrent injuries. And so this is a really sort of high stakes game, and there's a sense of urgency that comes with that. we also know that they're going to have significant comorbid structural and social challenges that we're going to have to address in order to help to partner with them to move their life forward productively. We also recognize that there's going to be serial traumas in exposures of these individuals' lives. Not only the fact that they've endured lots of things that many of us may not have had to endure in our own lives, but also the reality of being shot and stabbed and having to live with that and the trauma that brings with it in and of itself. And so addressing trauma and being trauma-informed is a critical sort of piece of the element. And then I think there's a recognition that our traditional healthcare system, the way that we're structured, it's just not set up to really support the survivors and their families in a way that I think are necessary to really move their life forward. And so recognizing that, I think it was important for us to try to identify some sort of framework or some sort of opportunity that we can try to innovate within our healthcare system to think about how we can better support these individuals. And this is where this concept of hospital-based violence intervention programs comes in. So what are these? These are programs that are located within or affiliated with a hospital, and they work on the premise that violence is preventable and that its re-injury is preventable, and that we can seize upon this opportunity called the teachable moment where somebody gets injured and they're open and reflective and potentially open to changing, and seize upon that to allow them to change their life around, put them on the pathway towards success. And so what we do is we pair a brief intervention, most commonly within the hospital wards, with sort of intensive case management and a wraparound support to help these individuals to sort of move their life forward more productively. And there's mounting evidence that shows that these programs work. As you all probably know, there have been many years for which there was a moratorium on funding to support firearm injury research, and that essentially resulted in a generation of knowledge loss. Lots of programs, lots of opportunities for individuals to learn and innovate and do things to help kind of change trajectory were lost as a result of that. And so there are studies there that are coming out and studies that have been done that these things are promising. You know, there's some programs that have been done at San Francisco University of California, San Francisco, as well as the University of Maryland at the Shock Trauma Center that show decreased recidivism in patients who are part of their program. There are other programs that show decreased involvement in the criminal justice for folks who've been part of their program. There's other programs that have shown significant cost reductions and cost savings with estimates of anywhere between $82,000 and $4 million over 4 years, depending upon how big of a problem violence is in the respective communities, as well as how successful those programs are. And so I think there's a burgeoning evidence base to really kind of support the work of these programs, but more work needs to be done. So in 2019, we were fortunate to initially have a grant that was funded through the Department of Justice via the Baltimore City Health Department to initiate Break the Cycle hospital-based violence intervention program. And then COVID happened, and then Monty started funding the program in addition to the Johns Hopkins Hospital. And so we developed a program called Break the Cycle. It's a hospital-based violence intervention program that engages victims of shootings and stabbings and individuals who've been violently assaulted. The goal of really preventing recurring injury and supporting both healing and growth moving forward for these individuals. And we are, I think, a really strong multidisciplinary group of individuals. The program was initially within the sort of umbrella of case management and care management within the Johns Hopkins Hospital, but it has been recently moved under the umbrella of the Division of Trauma and Acute Care Surgery, which I think is a great opportunity to really sort of align the services that actually take care of these patients most commonly, and providing them with the resources to really support these patients holistically. And we are a multidisciplinary team that includes case managers, social workers, violence division specialists, which are these two individuals that you see at the top of the screen, which are really the heart and soul of our program. And we also have physician and nursing champions from trauma, emergency medicine, as well as pediatrics that really work collaboratively to really try to figure out how we can support the program and support the work of really trying to change lives and support people that are undergoing really challenging times. And so how does the program work? Well, we identify individuals who have been seen at the hospital, who have been victims of shootings or stabbings, that are Baltimore City residents, and their age is 15 to 35, because that's the biggest sort of risk factor group for violent injury. And we provide trauma-informed care to them. We provide wraparound services. We really try to wrap our arms around them and provide them what they need and partner with them on this journey of lifelong recovery for them. And so we support them both through helping them to kind of identify what their needs are and help to keep them safe. We do a lot of motivational interviewing with these individuals and help them to sort of change the way they think about challenges and think about realities. We support our post-hospital discharge plans and do targeted interventions to really kind of support the goals that the patient develops and describes to us. And we really work not only within the hospital itself, we work with a lot of community-based organizations across the city to really partner to figure out how we can right-size what the patients need with the services that are provided across the city. And so there's a lot of work that's being done to try to figure out how we can better coordinate that. And we also do a lot of things that really focus on the goals that these clients establish, and whether that's helping them to get jobs, helping them to write resumes, and helping them to get employment, helping them to get mental health services to address the trauma that they've been experiencing. We do whatever we can to really support this individual. And so we really tried to use a trauma-informed framework to holistically look at what these individuals need and to partner with them, support them, and see not only their sort of acute needs, but helping them to think about what they need to do in order to attain the future that they want. And so we focus a lot on safety because individuals who've been traumatized, finding places that are safe and really establishing that sense of safety is really core to the trauma-informed framework. We work holistically with them, and we recognize that it's not just that individual that's suffering, it's their family. And so we work within the sort of family unit to try to provide support for them. We advocate for their needs, both within the healthcare system as well as in systems writ large around the city. And I think we really have worked diligently to try to establish trust and partner with folks across the city to really step into this really important landscape. And it really takes a village. You know, we're just one node in this giant ecosystem that's been established across the city of Baltimore and the greater state of Maryland to really try to provide services for individuals who've been victims of violence. And so we play our role to try to identify folks and to try to wrap our arms around them. And we try to engage with all the other members within the sort of violence prevention ecosystem to try to help keep our city safe. I think one of the other really cool things that we do within our hospital is that we recognize that Maryland is a relatively small state, and there's lots of hospitals within the state of Maryland. And we have CRIS, which is this regional information sharing partnership that allows us to not only understand what happens when patients are within our hospital, but what happens when they go to other hospitals. And so when we think about recidivism, when we think about other injuries and other things that these individuals are going to, if I see a patient that's a part of our program, if they go to another hospital, we get a flag that says, hey, they're patients at another hospital. So if they're there for a violent injury, our program director can look out for them and say, hey, what's going on, and figure out how to support them. And so it really allows us to have more longitudinal support and to be able to help leverage resources across the state of Maryland for folks who are working with these individuals to make sure that we are not doing duplicative work and helping to sort of leverage whatever resources we have to have the biggest bang we can. And so what does it sort of look like for our program? This is data for, I believe, the last a couple of years in our program. And you see on average, you have about 500 individuals that come to the hospital with shootings or stabbings, about 2/3 of which are going to be shootings, a third of which will be sort of stabbings. And the sort of big red circles suggest that a lot of the folks that are coming to us are coming to us from East Baltimore, which we would typically expect. About 86% of the individuals who come in with shootings or stabbings in our hospital are Black men. 14% are identify as women, and the overall majority of them, I said, are Black. If you look at the sort of age group breakdown, about 63% or so of the individuals that come in are between the ages of 15 and 35. And about 7% are actually 5 to 14. And so it's sort of young kids who are being impacted. And so trying to figure out how to right size a program for them is going to be important. The other thing that I think is important to recognize, about 65% of the folks that come in will have Medicaid insurance. And so that's important when we think about long-term solutions around how to fund these types of programs and how to make these things sustainable. The services that we commonly utilize to support these individuals are oftentimes things like wraparound case management services. So really trying to figure out what they need and trying to align them with the relevant kind of services, whether it's within a hospital, whether it's in the across the city or in other institutions. We provide a lot of motivational interviewing and life coaching, and really, try to figure out how to get people to rethink how they respond to the challenges that they're facing, and ultimately helping to rethink so that they can engage in different behaviors is going to be a really critical piece of that. There's a program called ROCA that exists in the city, and that's one of their big ways that they make an impact is they really focus on this cognitive behavioral therapy where they help people rethink how they respond to a situation. And our staff has actually had CBT training through ROCA to actually engage in some of those same kind of practices. We also do a lot of work in terms of doing victim services, so getting them appropriate psychological counseling and helping them to kind of support the trauma that they've experienced, helping them to get resources for legal aid. And I think the big deal is sort of this idea of relocation. When you think about safety, you take an individual who's been shot or stabbed and feels unsafe in their community, and then you tell them to go right back to that same neighborhood, to the same house, to the same place where they were shot. That doesn't generate a lot of sense of safety, and oftentimes result in individuals doing things that are going to put them at further risk of being harmed. So really trying to figure out how do we keep our clients safe is really important. So relocation assistance has been a big deal for our program. And over the last few years of being wildly successful, our recidivism rate is about 3% or so, about 2.5 to 3%. And if you look at our numbers over the last 12 years, there's been nobody who's been involved within our program that's been re-injured. And so I think our staff is doing a remarkable job of really trying to partner with patients to see their humanity, to see what it is that they need, and to really kind of partner with them to help move things forward more productively. And so there are certain lots of next steps for our program. We want to expand the coverage. We currently have 2 violence intervention specialists and a social worker who are the kind of mainstay of our program. Is we would love to sort of expand the team to be able to have more hours of time that are coverage, and we can identify more patients that we can support. We also want to expand to the pediatric side of the hospital, as well as to our sister hospital at Bayview, recognizing that we see similar types of patients at those places. And so we need to be one institution that has the same kind of standard, same sort of resources for folks that come in, irrespective of where they are. I think you have to recognize that the work that our violence individual specialists do is tremendously taxing. We talked about the trauma that individuals who experience violence endure, but the fact that our staff works with these patients on a day-to-day basis, and we help in kind of endure the secondary trauma, the trauma of being an empathetic person who is hearing these stories and helping to support these individuals is also traumatic, also very, very difficult. So really trying to figure out how we can better support our team so they can stay healthy and they can do the best job they can to help support our city. We want to engage in a really robust evaluation program, recognizing Hopkins is known for our world-class research, and so really kind of leveraging the brain trust that exists both within the School of Medicine and the School of Public Health to figure out how we can best understand what we do that works and what things we can do that can be translatable not only across the Western Maryland, but also across the country nationally. And I think the other sort of side of it is recognizing that there are significant needs that our clients have that or can be a challenge to achieve sometime. And so trying to identify alternative funding sources to be able to help support clients to be able to get the things that they need to land on their feet, I think is another thing that we want to do. And so that's a little about the program, it's a little about a bit about our approach and where we see ourselves going forward.
Excellent. Thank you, Dr. Irvin. Well, first, I'll just say this. Look, you have impeccable credentials, and you could have gone into almost any area of the medicine that you could have chosen you would have wanted. And you could have done it anywhere in the country. The fact that you've come here to Maryland, to Johns Hopkins, and you've engaged in this work, I just want to say thank you for that, because we are tremendously grateful for your work. And I think that our state's benefiting greatly from it. So thank you for that. I'll say this. Look, I've got a couple questions. You answered a number of them in your presentation, and I want to make sure we get to some of the questions from our participants or from our viewers. But I want to make sure that I capture this moment real quick right at the end of your presentation. So when we first met, we talked. You came to the Judicial Proceedings Committee, and I'm chair of that committee. We deal with all the criminal and civil justice issues facing Maryland. And with regard to gun violence, we can adjust penalties for people that are gun traffickers or illegal possession, or what happens when you injure somebody. Civilly, we can go after gun manufacturers, hit them in the pocketbook. But those things are all kind of ex post. Those are things that happen afterwards. They're not preventative. A lot of what you do is preventative. Most of what you do is preventative. So something has happened, something terrible has happened, someone's experienced trauma. They've come to get physical care. We often talked about the gap between all of the other wraparound services and supports that individual will need when they walk out of the hospital, whether it be to deal with their physical ailments, but also the psychological and other supports that they may need. What I was really impressed about is you talk about the trauma-informed approach, and you're nested within an academic institution, one of the best institutions on earth. And so some people will be skeptical, is this just an academic exercise or something that's more academic? They want to know more about the practical application. You talked about people that have moved gun violence have a recidivism rate of something north of 60%. And whereas your participants in your programs have had something like 3% and none in the last 12 months. Can you just talk a little bit about your impact in Maryland? And I want to move on to a couple of the other questions about the future of the program and get into some of the viewer questions.
Yeah, I think it really is indicative of a really commitment to trying to see the humanity in people. I think what our program does is they invest in people, and they take individuals who've been hurt, who may not have had the greatest experiences with other sort of sectors of society, and our violence intervention specialists see them. They see their humanity, and you're really trying to wrap around that. I think at Johns Hopkins we've spent many years actually trying to commit ourselves to trying to embrace this culture of trauma-informed care. This is not something that just started over the last 2 years. It's something that I think has been going on for at least a decade that I've been there, And so I think a lot of our departments really try to not only understand and be able to recognize the signs and symptoms of trauma. We try to think about how do you respond to individuals in a way that doesn't re-traumatize them. How do we create policies that are more sort of informed of the way somebody who's dealing with trauma might experience their care and try to be responsive to that. And I think those things have really sort of been really tremendous. But I think life is hard, and I think for a lot of people, just having people that they can trust, having people who really care about them, and as I said earlier, I think Nadir and Isan, who are our violence individual specialists, are really the heart and soul of the program. They are individuals who have a tremendous story in and of themselves, and they have a tremendous gift, and they take that gift and they go and they give it to each and every one of the patients that they encounter. And so I think it just shows the importance of really kind of centering the humanity of these individuals and trying to figure out how we can grow. And then I think the other side of it is just recognizing that we're just one piece of a bigger puzzle, and that there's tremendous resources all across the city, particularly that have been sort of spurred by a lot of the funding that came out of ARPA, the American Rescue Plan Act, that really kind of helped to breathe a lot of life into a lot of the service agencies that really help to interface with these individuals. And so really trying to think about how we can better leverage those opportunities. Like, in fact, in June, we had our second Break the Cycle summit. That was a citywide summit that actually brings stakeholders not only from the city of Baltimore, but across the state together to kind of think about, like, how do we do this job better? How do we learn from one another? How do we build bridges? How do we better support one another? And so I think really, we're trying to learn this work. We're work in progress, I would say, but I think we have folks who are really committed to the mission, really committed to working across silos, across institutions, across whatever sector necessary to help support clients. And I think like that, plus the sort of will of all these other institutions within the state and within the city who are working collaboratively to try to move the needle has really been what's been effective.
No, I appreciate that. And your work is really helping from the policymaker perspective. Your work at Johns Hopkins is helping us get out of our silo of, what should the criminal or civil penalty be, and be more proactive and responsive there, and infuse more resources into these community-based programs. So with that said, I want to turn to a question from Phyllis, who's watching. And this is a very good question. So she says, how does this program help Johns Hopkins patients and others who are not in Baltimore City? As we talked a lot about city resources. So the folks that are coming in, getting treatment, how does this help people across the state of Maryland?
Yeah, so, we would identify individuals who because of the initial funding streams of our program, we had certain geographic limitations. And right now we have two violence intervention specialists and a social worker who are kind of on the soul of our team. And so we don't have the bandwidth to take care of all 500 individuals that come in shot and stab. And that's just a reality of the situation. And so what we would do is we would try to unify a program that's in their county, that's in their area, and try to get them connected to these resources. And so I think about, if I'm thinking about systemic fixes, I would think that like every hospital that is a trauma center, whether level 1, 2, 3, whatever type of trauma center, should have a program that's established to address gun violence, whether that gun violence manifests more as interpersonal violence and homicide, or if it's more like a suicide challenge in that respective area. But each hospital should have these types of programs in place, and trying to connect individuals with those resources, I think, is what's best. Because it's not just like that one day visit that matters, right? It's the longitudinal engagement. Like there's our violence intervention specialists carry a panel, right? And so they are longitudinally case managing these clients. And so it would do the program disjustice to have somebody that is, an hour, 2 hours away that can't come in and can't interact with our staff way that's necessary for them to really get the benefit of the program. And so we try to, as much as possible, right size the program. If there are individuals that are outside the age group, sometimes we are able to kind of accommodate those individuals, or we'll try to figure out what other programs we could potentially connect individuals to. And so I think that the idea is that, the resources are constrained, and we do the best with what we can. But, ideally, we'd be in a situation where nobody would be ever come to a hospital as a victim of violence and not have somebody that's a staff member of that hospital that can, speak to the specific needs of that individual and really help to support them in the way that they need. And I think ultimately, that would be a great systemic fix across the state. And I think this sort of new office of violence intervention that is going to be established, I believe in October or so, is a step in that direction to start thinking about how we do this better from a statewide perspective.
That's I appreciate that. So I want to turn now to a question from Al. It's interlaced with one of the questions I was going to ask you anyway, which is, so you talked a little bit about the program, how the program got started with the infusion of some federal money. Obviously, Hopkins put considerable amount of resources behind this program. So what state policies and resources have made the program successful, and what do you need to further enhance it? And then what were some of the roadblocks that you ran into to get this thing started in the first place?
Yeah, I think some of the state level stuff that I think is really going to be really seismic for these types of programs. One is the sort of idea that you can have some sustainability from these programs by being reimbursed for the work that the violence intervention specialists do. So that's a huge deal. Like that Medicaid, as I told you earlier, 63% of our patients that come in have Medicaid insurance. And so the ability to actually have some ability to be reimbursed for this intensive case management and have some sustainability is a big win. I think the fact that people like yourself, Senator Smith, work tirelessly to establish policies and laws in the states that make carrying guns and having access to guns really consequential for people if they're doing it unlawfully, I think is really evidence-based practice that we know that helps to kind of reduce homicides in communities. But I think also like having the advocacy for people who are saying this is not good enough. This is something that we have to figure out how to move the needle on. I think is important. That I think from the statewide level, we also do a lot in terms of being able to try to get funds from the state of Maryland to fund programs of this nature. So really, I think really continuing to pour resources into the space and start to kind of fill in some of those gaps. I think a huge area is kind of thinking about how do we better support the psychological needs of patients who've been victims of violence, and how do we sort of create more mental health kind of supports for folks that are going to be community centric and things that really kind of speak to the challenges that folks face. I think is important. I think one of the challenges that we do face, though, is that, like I said earlier in the talk, I think looking at some of the challenges that our patients face are not things that can be easily fixed within the resource that we have within the healthcare system. So we're frequently like going to community partners, other institutional partners to try to get our patients connected to those sources. But they're the one place that does X, Y, or Z, right? And so they end up having a long line of individuals who are waiting to try to get that same resource as well. And so I think just recognizing that there's a lot of that exist, I think is important. I'll say the other thing that's I think more recently is coming up is just the idea of really having more nimble ways to help get people relocated to safety. A lot of our systems are based upon getting people connected to bureaucratic systems that then kind of adjudicate whether or not they're an appropriate person for relocation services, and then they get connected to care. But a lot of times, the decisions that our clients or our patients are trying to make are day to day, hour to hour, to try to keep themselves safe. And so, having more nimble access to those kind of resources for people who are actually doing the direct services to support these clients, I think is something that we should think about from a statewide perspective, how to do better.
Thanks. So we've got a couple more questions. I want to get to one from Cindy. And one of the quantum leaps that we've made with how we view gun violence in the last decade is we viewed it now it's a public health crisis. Mm-hmm. That's a public health issue. And so Cindy says, do you think that similar programs can help with other public health crises like drug addiction or domestic violence? And I like this model, and maybe it's potentially applicable to other public health crises that we face in the state of Maryland. What do you think?
Yeah, I think there's a lot of synergy. There's a lot of similarities between the risk factors for individuals who are struggle with substance use versus individuals who are victims of other forms of violence. And so yeah, I think there's certainly a great opportunity to do so. I believe it's at Sinai. They have a center. I think it's called Center for Hope that they have there. And their center is focused on all sorts of violence. And so not only do they do interpersonal violence, they do intimate partner violence. They do child abuse and elder abuse. They have it all kind of enveloped underneath one kind of umbrella, and that's the way that they kind of navigate stuff there at their institutions. So there's different sort of models by how people approach it, but there are certainly similarities. And part of the reason why I frame what I do social emergency medicine is I think there's a lot of similar upstream factors that result in people engaged in high-risk behaviors, whether that's substance use, whether that's engaged in the risk of sexual behavior and acquiring HIV, or injecting drugs, or violence. There's a lot of things that I think that we can address from an upstreamist perspective that can potentially help to mitigate a lot of these challenges. And so, yeah, I think one of the beauties of the public health perspective is a proactive approach that says, let's think about all these different areas these different silos that interact with all these different individuals, and we figure out how we can address these issues like more holistically. And so I do agree that these types of efforts will be useful.
No, I hear you there. I think that perspective is going to be invaluable. That's why invaluable for policymakers, and that's why I was glad you came down to Annapolis and to get us kind of out of our four corners and understand that there are multiple applications for proactive approaches like this. So, not just my committee, but all four of the Senate committees. This type of information would be invaluable to how they approach policymaking in multitude of different areas. So, I really do appreciate that. We've got a question from Sheila who wants to know about so the General Assembly. How is the program funded? We talked a little bit about that, but and she says, hey, the General Assembly just raised the vehicle registration fees. Does some of that money go to the Hopkins Break the Cycle program, and how much? I can answer part of it, but you're more familiar with the initial funding piece, and I can go ahead and go budget part.
Yeah, I would say I have no idea if any of how much that money is going to come to us from like a household perspective. Um, um, but yeah, I would hope so. I know some of those. Yeah, I'm not sure about the specifics of that. And
But so we did. And look, we in Maryland we face a significant budget shortfall. So we're in out years. So we've got a structural deficit that we deal with, and like every state in the union, we have to pass a balanced budget. So we did that this year without raising taxes or revenue. But we have raised some fees, and this is one of them. And money is fungible, so I couldn't speak to this where that money is going to go directly to this program. I couldn't speak to that. I do know that this money will be going to stand up and support the new gun violence prevention initiative. The governor announced that the General Assembly passed, which is going to become effective October 1, which will help coordinate resources to deal with gun violence across the state and use it through the framework and the lens of a public health crisis. Money will be going to that, but as I said, money is fungible in the budget. And so for this specific program at Hopkins, I'm unaware of a line item that goes directly from our state monies.
I don't know if there's money that's going to the trauma center or other things, but yeah, it's hard. Nothing to my understanding is
excellent. So wanted to talk a little bit more about some of the next steps of the program. You talked about expansion. Can you just talk a little bit more about what are the next steps? I mean, what is FY 25, 26 look like? What's in your mirror right now? What's going on? What are you thinking about?
Yeah, so the program, as I said, recently moved to the Division of Trauma and Acute Care Surgery, which is, I think, a great home for the program. And so, we're trying to really kind of think about how do we better support the patients within the system. I think we want to figure out other funds and other ways to get funding, and so I'm hopeful that there'll be some more funding analysis that come out from the state or the feds around ways that we can sort of continue to get money. We're also receiving some funds through the mayor's office in neighborhood safety and engagement to help kind of support the program, and so continuing to try to tap into those resources. But we're also looking to figure out other opportunities to expand resources, and so we're actively working on a grant right now to get support to do an evaluation of the program. And so, I think part of the work is you want to have a sustained workforce that's able to kind of continue to do their work without having to have ebbs and flows in funding to support those individuals. But then I think funding these other issues around, like, how do we expand the program? How do we get more personnel? How do we see what works and what doesn't work? A lot of that requires funding. And so we're looking at both federal funds to kind of do that kind of piece, but also philanthropic funds as well. And so really, I think trying to just get the framework in place to really expand the work that we're doing and leveraging whatever funding resources we can and do so.
And to Sheila's question and then to the question coming up ahead, but as a policymaker, I'm on a policy committee, not a budget committee, but I can go to the budget committees and say, look, I deal with gun violence in my committee. This program has had a recidivism rate of 3%, over the last 12 months, 0, with 3% in the history of the program. We're saving money here. We're saving lives, but also money. Invest in this. Because I think that's why it's so important to have this exposure in my committee, because we're not looking for carceral solutions. We're looking for preventatives when people think in the first place. So I think count me as a partner for helping you secure more funding on the state side as an advocate for that, because it will save us money, it'll save lives, and it'll have better outcomes also. So that's a good thing.
No, I would certainly appreciate that.
Jennifer has a question. She says, I wonder if you've ever heard or worked with the Harold Pollitt Work Lab at the University of Chicago. It's a University of Chicago crime lab on reducing gun violence and prevention on the offender side. Have you ever heard of that?
No, I've never heard of it. I've done a lot of work with one of these household-based violence intervention programs. From my fellowship, I spent time in Philadelphia working with a program called Healing Hurt People, which is established by John Rich and Ted Corbin, who were some of the originators of this concept. So I've done a lot of work with HVIPs. I haven't done anything specific with Dr. Hawk and his group, but I'm excited to Google it and take a look at the work that they're doing and see what we can learn and see what we can potentially incorporate to the stuff that we do here.
Good thing is you can probably call them up as well.
Yeah.
Let me learn something about your crime lab. All right. I mean, look, you mentioned this in Indianapolis, but also here today as well. A lot of the folks that are victims of gun violence are also more likely to be the perpetrators or have a higher degree of likelihood to be perpetrators of gun violence. So I think there is an intersection there all around prevention and treatment. So that's a good thing, and look forward to learning more about what's happening at the University of Chicago as well. All right. So we're coming up on the end of our time together. And so I really appreciate everyone who has listened in and participated and submitted the questions. Dr. Irvin, thank you so much for your work and for your time today. I do want to say, of course, yes. I'd also like to say, to thank those that listened in during the conversation. You can view more of this at the Hopkins own website, but you can also, for questions on how to be involved or to learn more about this series, you can go to gce@jhu.edu. That's again, you can go to gce@jhu.edu. Again, thank you for your incredible work. And this has been a really, really informative conversation. And I look forward to our continued work together with Hopkins and in the General Assembly.
I just thank you so much. Thank you for having me. And I want to say thanks to the rest of the members of the Break the Cycle team, Dr. Saccharin and Dr. Hoops and everybody else that's been tremendous amount of time trying to figure out how we can move the needle here in the city. So thank you all.